Hello everyone, Medic Level Up here. We're back again with another video, and today's video is going to be about pericarditis. Before we move on to dysrhythmias, we'll also be discussing myocarditis and some other pulmonary syndromes. For now, let's take a look at what the ECG is going to show when a patient has pericarditis. Stay tuned. So we're going to be talking about pericarditis, pericardial effusion, and pericardial tamponade. Let's start this topic off by talking about pericarditis. Now we all know that on an ECG, pericarditis is usually manifested at ST segment elevation, and this ST segment elevation is more diffuse in nature, as in it's present in all of the leads. There's very minimal reciprocal changes in these cases. If there is reciprocal change, it is only going to be present in leads AVR and V1, and it is going to be ST segment depression. If you look at the morphology of this ST segment elevation, it is more or less going to be like a saddle or with an upwards concavity, as opposed to the upwards convexity one sees with ST segment elevation in a myocardial infarction. The next thing is that pericarditis not only affects the ventricular phase, it also affects the atrial repolarization, which is the PR segment on an ECG. As a result, what tends to happen is that the PR segment is depressed on an ECG. This PR segment depression is going to be PR segment elevation on lead AVR because it's just looking at it from the opposite side. Now, if you combine the two findings together, you get PR depression and ST segment elevation. These two segments going in opposite directions is known as PR and ST segment disconcordance sign. So if you see an ECG which has PR depression and saddle-shaped diffuse ST segment elevations, think of pericarditis. There is one more sign we're going to talk about. It is known as the Spotic Sign. From beat to beat, what you will see is that the TP segment has a downsloping morphology. This is not that common, but is something to just bear in mind when looking at an ECG and having concerns over pericarditis. There are some phases of pericarditis that a patient goes through. Some patients will develop P-wave inversions in pericarditis. Now, this is important when we will discuss another topic subsequently in the same video. Let's talk about how you will differentiate between myocardial infarction and pericarditis. Well, number one, the ST segment elevation is going to be more diffuse in pericarditis, and it's going to be much more localized with a myocardial infarction. And you will also develop some abnormal Q waves in an MI. We already talked about this. The upward concavity is seen in pericarditis, and the upward convexity, or a tombstoning appearance of the ST segment elevation, is very typical for a myocardial infarction. Let's talk about pericarditis versus benign early repolarization. There is a formula that you can use for this. It's ST segment elevation divided by the T-wave amplitude, and is calculated in a similar fashion as shown here. So you take the number of small boxes of the ST segment, the number of small boxes of the T-wave amplitude, and then you calculate the ratio. Let's say, for instance, that the ST segment elevation over here was 1 millimeter, the T-wave amplitude was 6 millimeter, and that gives us a ratio of 0.16. If this ratio is above 0.25, it's pericarditis. If this ratio is below 0.25, this is benign early repolarization. In benign early repolarization, you will also see a characteristic notching of the J point as well. Moving on, let's draw a chest wall over here. You can see the heart over here, and in blue, we're going to encircle the heart around with a pericardial effusion. Now this layer of fluid is going to interrupt or block the flow of current towards the surface of the chest wall, and hence you will get low voltage complexes on the ECG. Now by definition, low voltage is going to be less than 5 millimeters in limb leads and less than 10 millimeters in precordial leads. You will also get a sinus tachycardia with a pericardial effusion. One more finding that I want to talk about is Qrs alternance. Qrs alternance is basically what happens when there is beat to beat variation in the axis of the heart. This is what an ECG will look like when you have electrical alternance. Now imagine that you have a lung superimposing the heart, and it is a patient who has emphysema. The distance between the heart and the chest wall is increased due to air trapping. And that's why you can get QRS alternance or low voltage. Obesity is another factor. And generalized body edema, also known as anasarca, is another feature in which electricity from the heart is transmitted as low voltage towards the surface of the heart. The triad of QRS alternance, sinus tachycardia, and low voltage is virtually diagnostic of a pericardial tamponade, and the next step is to get an echo ASAP. That's all for today. Let me know in the comments if this was helpful or not. Thank you so much for watching. Don't forget to like, share, and subscribe to the channel, and have a good day.